Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arora, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 410 of our pharmacotherapy series, which majors in lower gastrointestinal disorders. The first clinical case reads, TAC, a 24-year-old female college student, has had episodic, watery diarrhea, and colicky abdominal pain relieved by defecation for the past 9 months. 8 weeks before admission, the diarrhea increased to 3 to 5 semi-formed stools daily. The frequency of the stools gradually increased to 7 to 10 times a day 1 week ago. At that time, TAC noted bright red blood in the stools. Stool frequency has now increased to 12 to 15 per day, although the volume of each stool is estimated to be only 1/2 cupful. She feels a great urgency to defecate, even though the volume is small. She has not traveled outside the United States, her country of current residence, has not been camping, and has not taken any antibiotics within the past 6 months. She is allergic to sulfur, and takes only occasional over-the-counter acetaminophen for body aches or headaches. TAC complains of anorexia and a 10-pound weight loss during the previous 2 months. For the past 4 months, she has had intermittent swelling, warmth, and tenderness of the left knee, which is unassociated with trauma. She denies any skin rashes or any difficulties with her vision. A review of other body systems and social and family history are largely non-contributory. TAC appears to be a slightly anxious and tired young woman of normal body habitus. She is 165 centimeters tall and weighs 51 kilograms. Her temperature is 100 degrees Fahrenheit. Her pulse rate is 105 beats per minute and regular. Physical examination is normal, except for evidence of acute arthritis of the left knee and tenderness of the left lower abdomen to palpation. Stool examination shows a watery effluent that contains numerous red and white cells with no trophozoites. Stool cultures and an amoebiasis indirect hemagglutination test are negative. Other laboratory values include the following results. Hematocrit of 30%, hemoglobin of 8.1 grams per deciliter. White blood cell, WBC, count, of 17,500 per microliter, with 82% polymorphonuclear neutrophils abbreviated as PMNs. Erythrocyte sedimentation rate abbreviated as ESR, of 72 mm per hour. Serum albumin, of 2.8 grams per deciliter. Alanine aminotransferase, abbreviated as ALT, of 33 units per milliliter. Sigmoidoscopy showed evidence of granular, edematous, and friable mucosa with continuous ulcerations extending from the anus throughout the colon. So my first question to you reads, what is the most likely cause of TAC's diarrheal illness, and what is the evidence for this? TAC's presentation is typical of a patient with new-onset ulcerative colitis. Drug-induced, pseudomembranous colitis, and infectious, that is parasitic, causes of diarrhea have been ruled out by history. She has no travel outside the United States, no recent camping, no antibiotic use, and stool examination. As discussed previously, ulcerative colitis is an inflammation of the mucosal layer of the colon and rectum. Characteristically, the inflammation does not extend beyond the submucosa, and transmural ulcers are rare. On examination, the mucosa appears erythematous and is friable. Differentiation from Crohn's disease is made by endoscopic and radiologic evidence of continuous distribution of pathologic disease, as opposed to segmental, as well as the anatomic location, confined to colon and rectum. TAC presents with the classic triad of ulcerative colitis clinical symptoms: chronic diarrhea, rectal bleeding, and abdominal pain. Diarrhea is secondary to decreased colonic absorption of water and electrolytes and diminished colonic segmental contractions that normally serve to decrease the flow of bowel content. A good indication of the severity of a patient's disease is the volume of stool passed per day. Because the severity of the disease increases, incontinence and nocturnal diarrhea commonly occur. Stools are usually soft, mushy, formed, and often contain small amounts of mucus mixed with blood. In addition to diarrhea, the malabsorption of water and electrolytes causes dehydration, weight loss, as observed in TAC, and electrolyte disturbances. TAC's rectal bleeding is secondary to colonic mucosal erosions and occurs in most patients with ulcerative colitis. Generally, bright red blood mixed in the stools indicates a colonic origin, whereas blood-streaked stools indicate an anal or rectal origin. The anemia associated with ulcerative colitis is generally secondary to this rectal bleeding. It presents as a hemorrhagic or iron deficiency anemia, depending on the acuteness of the bleeding. Hemoglobin and hematocrit laboratory values often are decreased, as in TAC's case. Chronic inflammatory disease-induced hypoalbuminemia is often exacerbated by malnutrition. TAC's abdominal pain and cramping are caused by spasm of the irritated and inflamed colon. This abdominal pain is commonly associated with urgency to defecate. As illustrated by TAC, the pain is usually relieved with defecation, even though the stool volume may be small. TAC's arthritis and elevated ALT are indicative of the extraintestinal manifestations that occur in inflammatory bowel disease. Her nonspecific symptoms, i.e., anorexia, fatigue, weight loss, anxiety, and tachycardia, could become profound during an exacerbation of ulcerative colitis. Fever, leukocytosis, and increased erythrocyte sedimentation rate are also systemic manifestations of an inflammatory disease. Rehydration is important to assure fluid balance and maintain good renal function. Given her anemia, tachycardia, elevated erythrocyte sedimentation rate, and frequency of bloody stools, TAC's disease would be classified as severe. My next question to you reads: how should TAC's diarrhea be managed? Treatment of the diarrhea associated with ulcerative colitis is often difficult. In patients with mild to moderate disease, antidiarrheals, such as loperamide or diphenoksalate with atropine, may help minimize chronic diarrhea. Extreme caution must be used, however, especially in patients with severe disease because of the chance of inducing toxic megacolon, a life-threatening condition and medical emergency. For this reason, antidiarrheals are best avoided in patients with severe active disease, such as with TAC. Bulk-forming agents, i.e., psyllium, may be helpful for patients suffering from constipation caused by ulcerative proctitis. The next question reads, what agents can be used to induce disease remission in TAC? Corticosteroids are the most effective agents to induce remission of acute, severe exacerbations of ulcerative colitis. Clinical improvement or remission occurs in 45% to 90% of patients taking up to 60 mg per day of prednisone, with a recommended dose of 40 to 60 mg per day. However, corticosteroids are not beneficial for maintaining remission. One strategy to minimize adverse effects of corticosteroid therapy is to taper them by 5 to 10 mg per week over 1 to 2 months after demonstrated improvement. Unfortunately, a subset of patients will experience a disease flare if the corticosteroid dosage is decreased or tapered too quickly. IV corticosteroids are an important option, especially in patients who have poor oral intake. Patients with active distal disease can be treated with hydrocortisone enemas. However, topical 5-aminosalicylic acid therapy is more efficacious. Biologic agents and cyclosporine may be considered for induction of remission in patients with fulminant disease or have failed other agents. Given that TAC is of childbearing age, a pregnancy test should be obtained and results taken into consideration when choosing current and future drug therapy, particularly if pregnant or breastfeeding. Methylprednisolone at a dosage of 40 mg IV every 6 hours is ordered. So my question to you is, what are the treatment goals for TAC? The goal of parenteral corticosteroid therapy for TAC is to achieve a rapid therapeutic response as measured by decreased frequency of stools, decreased pain, and decreased fever and heart rate. This goal may be attained with a high initial dose, followed by a gradual dosage reduction to minimize the development of corticosteroid adverse reactions. Poorly nourished patients in whom oral intake is expected to be absent for more than 7 days should receive parenteral nutrition, and treatment should be continued until oral feeding is tolerated. An adequate response is defined as resolution of fever and tachycardia, improved patient well-being, and less abdominal tenderness on palpation. Diarrhea is usually considered to be resolved with 4 or less bowel movements daily. Stools are rarely formed at this stage, but macroscopic bleeding has stopped. Patients can then receive oral prednisone, a 5-aminosalicylic acid drug, and a light diet. If the patient does not respond within 72 hours of starting high-dose corticosteroids, infliximab or surgery may be indicated. Once TAC's symptoms are controlled, the goal should be to switch to oral corticosteroids and discharge her from the hospital. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 411.